Good morning. Today I'm going to present the most important update within the field of CKD-MBD. So I'm going to discuss the update under the following sectors: introduction, followed by the most important points in the lab, then the most recent update in the guidelines, KDIGO 2017, then osteoporosis and fracture, magnesium and vascular calcification, vitamin D in focus, beta H and hyperparathyroidism and the role of parathyroidectomy, and I'll end with CKD-MBD after kidney transplantation. Before I'm going to proceed in my presentation, please review all what was recorded before, especially the video on the last October 2016, because in this presentation I'm going to continue the update, so there is no repetition from this presentation. So I reviewed, after the last presentation in October 2016, I reviewed 103 articles. All these articles were published in 2017 and up to this moment, and I'm going to highlight them. So to start with, if you look at the symptom prioritization among adults receiving in-center hemodialysis, you'll find here the key symptom qualities factors factoring into prioritization depends upon the duration of symptom, financial impact, social impact, unpredictability, and frequency. And if we look at CKD-MBD, it is a frequent complication with financial and social impact. So we should look and concentrate. One of the important point is if we find drastic changes in CKD-MBD profile, like hypercalcemia, phosphate derangement, either very low phosphate or very high phosphate, and very low or very high beta H, mortality is there. So extreme values of CKD-MBD markers are associated with mortality risk in hemodialysis patients. This is why this topic is important, and I think it's not only restricted to hemodialysis, but within the different stages of chronic kidney disease. We don't like our patient to have this appearance. This is the clinical photograph shown here. This is a large globular lump protruding down from the hard palate, and this is the radiology X-ray and CT showing here the lytic lesion, and this is a complex cystic lesion. So it is the brown tumor of the bone, and this may be associated with untreated hyperparathyroidism. We don't like our patients to be disfigured because if we deal late, the outcome will be bad. What about the most recent update in the field of laboratory evaluation of CKD-MBD profile? This is one of the interesting articles still in press addressing the issue of diagnostic accuracy of biomarkers and imaging for bone turnover in renal osteodystrophy. Why? Because bone biopsy is the gold standard for evaluating the renal osteodystrophy, but it's very difficult, and the presence of professional pathologists who can interpret the biopsy is not available everywhere. That's why we are interested in this issue. So this is the CT scan showing the trabecular bone microarchitecture, and you can see here for distal radius and distal tibia there is a great difference between the control and the patient with chronic kidney disease. So trabecular bone microarchitecture is impaired significantly in a patient with chronic kidney disease. And here, these are the biomarkers for detecting low bone turnover. Here you can look at the area under curve. Intact beta H, the area under curve is low. So, and here, if you look at the intact BINB, which here is procollagen type 1 N terminal propeptide. So the area under curve for this is 0.79, approximate 80%. This for intact, and the total BINB. Bone alkaline phosphatase, the area under curve is 82%, and for total alkaline phosphatase it is 0.75, and for CT scan it is 0.76. So it seems that if we combine radiology with the biomarkers, we may have a good answer. And here again, intact, this is for high bone turnover. Look here, intact PTH was of low predictability for low bone turnover, but it is fine for the area under curve is 0.76 for detecting the high bone turnover. So to conclude from this study, abnormal bone turnover of renal dystrophy in advanced chronic kidney disease can only be diagnosed using bone biopsy because this is a gold standard. However, this is an invasive and painful procedure, and thus it is rarely performed. This study found that 3 bone biomarkers, bone alkaline phosphatase, intact BINB, and TRAB5B, and high resolution bone imaging of distal radius can discriminate patients with low bone turnover from those with non-low bone turnover, as assessed by bone histomorphometry. Hence, the biomarkers and bone imaging may have the potential to replace bone biopsy, particularly in discriminating patients with low bone turnover. They may also be useful in selecting patients for future clinical trials that aim to reduce their fracture risk. So I think it is a very important. Regarding Klotho and FGF23, fibroblastic growth factor 23, is there any new in this issue? This article, this review article, addresses the importance of FGF23. FGF23 is the king, and the effect of Klotho is secondary to the FGF23. And here, this is the level of FGF23, and here this is the Klotho. This is FGF23 in green color, and this is the Klotho receptor here. You can find the membrane. So, single pass transmembrane protein with a small intracellular and large extracellular domain, it is the FGF23. The extracellular part of the protein consists of 2 tandem, as you see here, Q1, Klotho 1 and Klotho 2, which share homology with family 1 glycosidases. There are 3 isoforms, just to fix this important statement. There are 3 isoforms of Klotho protein: the full length transmembrane form, a shed soluble form S Klotho, produced by cleavage of extracellular part of the protein through membrane anchored proteolytic enzyme such as ADAM17, and a truncated soluble form produced by alternative splicing of Klotho mRNA. The truncated Klotho protein isoform lacks the Klotho 2 domain in mice and man, whereas the shed form consists of Klotho 1 and Klotho 2, but lacks the transmembrane and intracellular part of the protein. So the key message from this review article is that FGF23 is the key player in these issues, because when FGF23 binds to its receptors, it leads to cascade effect of kinases with subsequent affection of phosphate here. So downgrading of phosphate leading to reduction of phosphate reabsorption by proximal convoluted tubule. In the same moment, it increases calcium reabsorption from distal convoluted tubule. So we should think of all these points that FGF23 is the main player. This is a study including 587 children with mild to moderate chronic kidney disease, and the aim of the study is to assess the relationship of the level of FGF23 and left ventricular hypertrophy in children with chronic kidney disease. And if you look here, if estimated GFR is above 45, the higher the level of FGF23, the bigger the heart and the left ventricular hypertrophy is increased. So, and as you see here, is significantly associated with increasing left ventricular hypertrophy, but with low GFR, the relationship is not constant. So, FGF23 is linked to left ventricular hypertrophy with a slight preserved kidney function, and irrespective to the model, the higher the FGF23, the higher here the higher the risk for hypertrophy, the odds for left ventricular hypertrophy if estimated GFR is above 45. However, here there is no consistent effect. So again, the higher the FGF23, the higher the risk of left ventricular hypertrophy for children with GFR above 45 ml per minute. Again and again, this article addresses the interplay of different hormones and parameters of CKD-MBD with the heart. And the take-home message of this article, measuring circulating level of beta-H, parathormone, vitamin D, FGF23, and Klotho can be a useful tool to better understand their paracrine and endocrine roles in the pathogenesis of cardiac complication beyond the renal disease context. Again, CKD-MBD is not restricted to bone, but as you see, it can affect the heart as well. The magnitude of cardiovascular risk exerted by high FGF23 levels is strikingly greater than exerted by vitamin D, beta-H, and even hyperphosphatemia. So it seems that FGF23 is the key in the relation to the heart. The failure of vitamin D supplementation to confer cardiovascular protection could be due to other associated comorbidities such as renal dysfunction or the basal level of important mineral components including FGF23 prior to vitamin D treatment, which were not considered in clinical trials. FGF23 damages cardiac tissue by direct mechanisms, many of which remain to be discovered, particularly non-phosphatoric mechanism that impact intrinsic cardiomyocyte contractile property. There are many gaps in our knowledge related to the physiological role of Klotho in the heart that have to be filled before establishing soluble Klotho as cardioprotective therapeutic options. Again and again and again, FGF23 is the key player as shown here. What about the trajectory, the change that in the trend of FGF23? Is there a link between the change and mortality? This study addresses this issue because it studied the longitudinal FGF23 trajectories and mortalities in patients with chronic kidney disease. And the significant statement is elevated fibroblastic risk factor 23 measured at a single time point are strongly associated with mortality in chronic kidney disease. But it is not known how FGF23 levels change over time or whether rising values predict risk of death. In this case, cohort study nested in the chronic renal insufficiency cohort study, FGF23 levels rose rapidly over 5 annual time points in only a minority of participants. In fully adjusted analyses, This group was at more than 15-fold higher risk of death than the majority of participants whose levels remained stable. Participants with slow rising FGF23 levels also were at approximate 4-fold higher risk of death. FGF23 levels are stable over time in the majority of patients with CKD, but serial measurements identify smaller subpopulations with rising levels and exceptionally high risk of death. And if you look, this is the study, how the study is performed and follow-up is done, and this is the different trends of FGF23 here. If we compare the hazard risk of death for patients with rapid rising FGF23, you can find here there is increasing mortality with rapid rising level of FGF23 with serial monitoring. So I think the term serial is very important, because we should look at the parameters of CKD-MBD, serum calcium, phosphorus, PTH, etc. in serial manner, not one point of time. And here in this study, serial follow-up of FGF23 declares that rapidly rising FGF23 is a very bad risk factor associated with high hazard risk ratio of death, and this was the highest among other risk factors like reduction of GFR, systolic blood pressure, or hyperphosphatemia. So again and again, the FGF23 is an important predictor. And this is very interesting, because this study is not addressing patient dialysis, but addressing critical ill patients for whom renal replacement therapy was done in the domain of acute kidney injury. So this acute kidney injury are not prevalent dialysis patients. If you look, either C-terminal or intrinsic FGF23 are associated with odds ratio of mortality for 60-day, 2-month mortality, and the higher the level of FGF23 in critical ill patients with acute kidney injury, the higher the mortality and the lower the survival. Again, very high level is associated with higher mortality. What about alkaline phosphatase? This is a very interesting review article about the role of alkaline phosphatase in diagnosis and treatment, because it is in this, as you see in the title, it's a novel treatment target for cardiovascular disease in chronic kidney disease. Why? We have in human we have isoenzymes, 4 gene encoding alkaline phosphatase isoenzyme in human: intestinal, placental, and germ cells, alkaline phosphatase. And these intestinal, placental, and germ cells alkaline phosphatase are tissue specific, whereas the tissue non-specific isoenzyme is present in several tissues, including bone, liver, and kidney. So let us fix this important point. So the higher level of tissue non-specific alkaline phosphatase expression or activities is associated with endothelial dysfunction, inflammation and oxidative stress, and pyrophosphate inhibition, with subsequent vasodilatation abnormalities, cytokine activation, atherosclerotic changes, and vascular calcification, with the end thromboembolic and cardiovascular events, mortality, and hospitalization. If we interfere with this high level of tissue non-specific alkaline phosphatase by either direct alkaline phosphatase inhibitor or epigenetic inhibitors, or using calcium mimetics molecule and vitamin D analogs, this may help in reducing the bad effects of alkaline phosphatase. The high level of tissue non-specific alkaline phosphatase are increased because of bone disease, chronic kidney disease, cardiovascular disease, or by genetic factors. So all these factors lead to increasing the tissue non-specific alkaline phosphatase with all these consequences. On the other hand, high level of intestinal alkaline phosphatase is important because it is considered as anti-toxin, because this high level of intestinal alkaline phosphatase is increased in sepsis and acute inflammation, trying to detoxify endotoxins and inactivation of cytokines and oxidative stress, with subsequent renal protection and anti-inflammatory effects. So if we understand the value of tissue non-specific and tissue-specific alkaline phosphatase, we can tailor treatment in the future, targeting how to interfere with alkaline phosphatase to gain the important effect and to avoid the bad effects. Another aspect added to the issue of CKD-MBD is the gland tissue and the circulating ADAM 17. ADAM 17, here this is the difference between patients with primary hyperparathyroidism and the secondary hyperparathyroidism. If you look here, the most important issue is the significant increase of the ADAM 17 within the secondary hyperparathyroidism. So it is disintegrine that is increased in this disease, which is secondary hyperparathyroidism. And as you look here, there is a link. Furin is a substrate, and hyperhemocysteinemia increase ADAM 17, and ADAM 17 is associated with increasing TNF-A, and here the furin is a substrate to change proparathormone into parathormone. So it seems that there is a link between ADAM 17 and the parameters of CKD-MBD. Regarding sclerostin, which is produced from osteocytes, leading to bad effect on the bones if it increased, because it increases osteocytic Renal production, so followed by osteoclast activation and increasing bone resorption, and reduces the lipoprotein receptor 5-6 co-receptors, so it blocks the Wnt B-catenin signals, so it inhibits bone formation. So high level of sclerostin, which is produced from the bone cells, is associated with increasing bone resorption and reduction in bone formation, leading to osteoporosis. What about the new 2017 guidelines? In 2017 KDIGO guidelines, there was a revision of 15 recommendations, and one of the most important change is in the use of bone mineral density in testing to assess fracture risk in patients with CKD. So in patients with CKD, starting from stage 3A to stage 5D on hemodialysis, with evidence of CKD-MBD and or risk factors for osteoporosis, the guidelines suggest bone mineral density testing to assess fracture risk if results will impact treatment decision. And if you compare to 2009 KDIGO guidelines here to the reverse, in 2009 the guideline suggests that BMD testing not to be performed routinely because bone mineral density doesn't predict the fracture risk. So if you look here in 2009 and 2017, this is the max. This is extreme change from advising not to do DEXA scan to detect bone mineral density to suggesting the value of doing this test to predict fracture. And this is a summary for the guidelines. And here these are the different axes of CKD-MBD on bone, the calcium and phosphorus, vitamin D and beta H. So for beta H, in patients with pre-dialysis CKD, optimal beta H level is not known. So this is a gap in the information of CKD-MBD. So our role is to evaluate and detect those patients with progressive rising or persistent high beta H. So this is a very important, again and again, serial follow-up. In dialysis patients requiring beta H lowering therapy, use of calcium mimetic, calcitriol, or vitamin D analog or combination, and this is 2B, suggestion based on moderate evidence, and they are written in this order, not of efficacy, but according to the alphabetical. So this is the important point to be considered. And for the bone, suggesting bone mineral density testing, as I mentioned in the previous slide, and this is a suggestion based on moderate evidence of research. And when considering treatment choices for CKD patients with low bone mineral density or fracture, take into account biochemical abnormalities and the progression of CKD with consideration of a bone biopsy. Again, this is an important, interesting point. He went to order bone biopsy, and I think this is a change in these guidelines. Regarding calcium, the most important is to avoid hypercalcemia and using of dialysate calcium in this range between 1.25 to 1.5 millimole per liter. This means 2.5 to 3 milliequivalent per liter, and restricting the dose of calcium-based phosphate binder, because the most important problem is hypercalcemia. And here in the regarding phosphorus, lowering elevated phosphorus level toward the normal range and limit dietary phosphorus intake. This is interesting, especially food additives, as I'll mention in one of the slides. Regarding vitamin D, in patients with pre-dialysis, CKD, calcitriol and vitamin D analogs should be routinely used. So this is should not be routinely used, and whenever we use them, it is better to monitor the CKD-MBD profile. And the commentary on this guideline is this is the evolution of guidelines reflects our current understanding of the pathophysiology of CKD-MBD, which is not strong. A lot of gaps are there. So the quality of supporting evidence is at best moderate, and it reflects the face of uncertainty. So evolution in the face of uncertainty. And if you want to read the some points related to the KDIGO-MBD guidelines, you can read this review about the guidelines that was published in the Annals of Internal Medicine. And this synopsis focuses primarily on recommendations for diagnosis and testing for CKD-MBD and treatment of CKD-MBD that emphasizes decreasing phosphate levels, maintaining calcium levels, and addressing elevated parathormone in adults with CKD from stage 3A to stage 5 on dialysis and those receiving dialysis. So it is better to read this synopsis in details. And the most important point is to avoid hypercalcemia when treating secondary hyperparathyroidism. Here in the March 2018, we have a visiting professor, our colleague, Professor Amr Husseini, who came to us. He is working in the Kentucky University as an expert in the field of CKD-MBD, and when he delivered his talk about CKD-MBD guidelines, he started with these objectives, and it was very interesting and stimulating to understand our ignorance in CKD-MBD management. This means we have a lot of gaps that call for well done research to answer these gaps. And whenever the guidelines is not dependent on randomized control trials, still the management is not, we are not confident in the management. So we need more and more research. And just from his slides, if you look at 2009 and 2017, as you see, the evidence is even decreasing in 2017. Regarding osteoporosis and fracture, This is a very interesting point, and this from Professor Iman Sarhan presentation within the CKD chapter that was held on December 2017. December 2017, under the professor patronage of Professor Tariq El-Bad, the chief of the chapter of CKD. And here, this is the very interesting and elegant slide showing the osteoporosis in CKD with overlap with renal dystrophy. And here, to treat osteoporosis, it's better to look at all the parameters of CKD-MBD, looking at laboratory parameter, including calcium, phosphorus, beta-H, and vitamin D. And if we have the estimated GFR above 30 ml per minute, and looking at the parameters, and we find normal calcium, phosphorus, beta-H, and vitamin D, DEXA scan is needed, and treating the patients according to the general population rule in management of osteoporosis. If estimated GFR is less than 30 ml per minute with normal profile, DEXA, and the high bone alkaline phosphatase, we treat as general as this with some modification. If estimated GFR is less than 30 and we have abnormal profile with beta-H above 350, and so here we can manage and monitor of mineral bone disorder prior to consideration of osteoporosis therapy is necessary. Beneficial treatment with anti-resorptive treatment still need more evidence. But if beta-H is very low, this means we are afraid of the adenemic bone disease. In this issue, bone biopsy in this clear situation is needed, and in the borderline beta-H between 150 to 350, we need bone biopsy because if adenemic bone disease is there, this is a real contraindication for anti-resorptive treatment. I think this is a very nice algorithm for treatment of osteoporosis, and this study, this is a meta-analysis of 13 trials showing the benefits and the harm of osteoporosis medication in patients with chronic kidney disease. And if you go in details with this systematic review and meta-analysis, the effects of osteoporosis medication on mineral bone density, fracture risk, and safety among patients with CKD are not clearly established. Sorry for that. And the patients receiving Romosozumab are also had more infection overall than placebo. So we should put this in our mind. And Romosozumab also is associated with hypocalcemia, and other trials showing terathitis associated with the hypercalcemia. So every drug has its limitation and side effects, specific side effects in the presence of chronic kidney disease. So I advise that we can read. The most interesting point, none of the trials reported on hyperphosphatemia, hypophosphatemia, hypersensitivity reaction, or osteonecrosis of the jaw related to the use of bisphosphonate. So it is interesting points. Regarding sclerostin, if we use humanized anti-sclerostin, Romosozumab, which blocks the bad effects of sclerostin that I mentioned before, because sclerostin increases resorption and decreases bone formation. By blocking sclerostin, we will improve bone formation and reduce bone resorption. And this is one of the studies that discussed the issue of Romosozumab, not within the CKD domain, but in postmenopausal women. Study included 4,000 patient postmenopausal women with osteoporosis and fragility fractures. The patients were randomly allocated either to monthly subcutaneous Romosozumab 210 milligram or weekly oral and alendronate 70 milligram in a blind fashion for 12 months, followed by open label alendronate in both groups. What are the results? If you look here, the incidence of new vertebral fractures either after 1 year or 2 years, you can find here superiority of Romosozumab and continuing with alendronate. And here the density is higher in the lumbar spine and in changing the hip by, so Romosozumab is associated with higher increase in bone mineral density. And this is another study published in Lancet showing that Romosozumab is associated with high bone mineral density by DEXA and improvement of trabecular volumetric bone mineral density as determined by quantitative CT scan in comparison to teriparatides, with adverse effects comparable in between two arms. But in last May 2017, there was an FDA alarm because FDA rejects Romosozumab for osteoporosis and wants more data to agree about Romosozumab based on one of the studies in the phase 3 study that showed increasing cardiovascular risk factors and outcome in Romosozumab treatment. So we are still waiting if it will be approved by FDA or not, and I think it's under investigation from European Medical Agency. This is the most recent meta-analysis that is published in the current issue, April, of Callimetric Journal, and as you see, this regarding side effects, no significant abnormality by the use of Romosozumab, and it was associated with increase in the bone mineral density in comparison to other anti-resorptive treatment. Regarding fractures, this is a very interesting point because fracture is bad and adversely affect the patient's outcome, and it's very expensive and associated with immobility. So this is one of the interesting articles addressing modified creatinine index and the risk of bone fracture in patients undergoing hemodialysis. Here, this is the equation to calculate modified creatinine index, milligram per kg per day. You can go through the equation to calculate, and according to the calculation, we have different quartiles. Either this is the first one, second, third, fourth, and here the lower the quartile of skeletal muscle mass, as evidenced by the modified creatinine index, the higher the fracture. And the higher this index, the lower the incidence of fracture. Again, as you see here, the lower the quartile of modified creatinine index, the higher the risk for fracture overall in male sex and in female sex. Regarding the risk factors for fractures, reduced kidney function will lead to frailty, osteopenia, disorder of phosphate handling, suboptimal architecture, bone architecture, high or low bone turnover, vitamin D deficiency, hyperparathyroidism, neuropathy, visual defects, and gait disturbance. All these factors culminate together to increase the incident fracture event. Bone mineral density testing is recommended for patients with chronic kidney disease if a therapeutic decision is being considered. Most treatments for osteoporosis work equally well in patients with CKD, stage 1 to 3, and should be used as indicated based on data from the general population. Evidence gap in the optimal strategy for diagnosis, prognosis, and treatment for more advanced stages of CKD and for patients on dialysis still remain, and we need further research. But this is a very interesting guidelines for treating fracture by looking at the beta H, then bone-specific alkaline phosphatase, and then go ahead step by step in the management to know where we are going. So in this example, if the beta H is lower than 120, this is the beta H is than 120 picogram per ml. We'll look at bone-specific alkaline phosphatase. If it is less than 10 nanogram per ml, here normal or high calcium, normal or high phosphate, suspicion of a dynamic osteopathy, bone biopsy should be thought and considered. If there is osteomalacia, here we can give vitamin D. The second point if the beta H is less than 120 and the bone-specific alkaline phosphatase is above 25, in the presence of low calcium, no liver disease, no myeloma, no Paget disease, skeletal fissures in the pelvis and femur, bone biopsy is considered to look at if there is osteomalacia or there is no mineralization defect. If beta H is in this range between 120 and 600, according to the level of bone-specific alkaline phosphatase, it's less than 10 or above 25. In less than 10, with normal calcium and phosphate, here bone biopsy is considered. And here in the normal or low calcium, no liver disease, vitamin D receptor activators, discuss calcium mimetics, and if no response and if there is any problem, consider bone biopsy. If beta H is above 600 picogram per ml and the bone-specific alkaline is less than 10 with normal calcium, normal phosphate, consider vitamin D receptor activators, calcium mimetic, and if no response, we can think of parathyroidectomy. And if this bone-specific alkaline is above 25, this is severe hyperparathyroidism. We should go to the maximum medical treatment and we can consider parathyroidectomy. Regarding magnesium, magnesium is very interesting. This is a nationwide study done in Japan in hemodialysis patients, including 100,000 hemodialysis patients, showing that mild hyperglycemia is associated with significant reduction of the risk of fracture. So this should be our concept in dealing with hemodialysis patients, because as you see in this slide, magnesium is a new player in CKD. Too little is bad, and too high is bad too. Because magnesium is essential to avoid vascular calcification, for the well-being of the bone, for the binding of phosphate within the gut, for suppressing beta H, inhibit osteogenic transformation of vascular smooth muscle cell. So all these are beneficial effects of magnesium to be considered. And this is a very interesting editorial comment about magnesium supplementation in dialysis patients. And the most important point is to consider the level of magnesium within dialysate. I think 0.25 millimole per liter is very low. 0.5 is nice, and I think it's not associated with the risk of hypomagnesemia, because we don't like hypomagnesemia, because hypomagnesemia is bad. Regarding vascular calcification, this is one of the most important points that we should work upon. We should understand what are the factors that can lead to vascular calcification. All these factors can increase vascular calcification. All these factors can reduce vascular calcification, and I think we need further randomized control trial to show how to prevent rather than to treat vascular calcification. Vitamin D is essential because it is a very important vitamin D. As you see in this study, this randomized trial of vitamin D supplementation on assessing vascular function after vitamin D supplementation. In this study, the patients were randomized 1-to-1 ratio to receive either 2 directly observed oral doses of cholecalciferol, 300,000 units, or matching placebo at baseline and 8 weeks. In this study, cholecalciferol supplementation significantly increased endothelium-dependent brachial artery flow dilatation at 16 weeks, whereas placebo did not. So it seemed that vitamin D is important for non-diabetic CKD stage 3 to 4, and the vitamin D deficiency in these patients was proven because the level was less than 20 nanogram per ml. Another study showing the issue of the cholecalciferol, calcitriol, and vascular function in CKD. It is a randomized double-blind trial. Oral cholecalciferol 2,000 units per day, or calcitriol 0.25 microgram daily for 6 months. And here there was no difference in after 6 months of treatment with calcitriol or cholecalciferol didn't improve vascular endothelial function or improve inflammation in patients with CKD. Again, this is microgram, not milligram. Regarding this, another interesting study showing the superiority of vitamin D in reducing vascular stiffness in comparison to placebo. Here, the peripheral wave velocity or pulsed wave velocity is increased with placebo and it's reduced with vitamin D. This means that vitamin D supplementation and vitamin D analogs at fixed doses may achieve reduction in pulsed wave velocity in patients with advanced CKD because the treatment effects were attenuated when baseline pulsed wave velocity was included as a covariate. This finding should be replicated in large population and further studies. So it seems that we need further studies in this issue. BTH and parathyroidectomy. This is an interesting domain, as you see here. This is this was the level in earlier A, but nowadays it is considered above because of relative high BTH if it's above 300 picogram per ml. In the earlier guidelines, it was considered to the level lower level, less than this, but here it is above 300. Or low in stage 5, here it is less than 150. And all B here denote dialysis. So causes of the relatively low BTH in CKD stage 5 is relative hypercalcemia. This is why we should avoid hypercalcemia. And this is because of the use of calcium phosphate binders, calcium-rich diet, higher calcium concentration in dialysate. So we should be careful about the use of calcium-based phosphate binders, and in the same moment looking at the concentration of calcium in dialysate. Metabolic syndrome, diabetes, malnutrition, inflammation complex. We should think of all these issues in dialysis patients. Oxidative stress, peritoneal dialysis, advanced age, white race, BTH errors, high 1.25 hydroxy or 25 hydroxy vitamin D levels, administration of vitamin D, administration of calcium mimetics, administration of recombinant BTH tripartite, and anemic bone disease, or after parathyroidectomy. All these factors are causes of relatively low BTH, less than 150 picogram per ml in stage 5. Above 300 in stage 5, this may be due to hypocalcemia, in vitamin D deficiency or progressive CKD, urinary calcium losses by the use of loop diuretics, inhibition of bone resorption by the use of denosumab, Renal inhibitors, elevated fibroblastic risk factor, vitamin D deficiency, hyperphosphatemia, black race, resistant tertiary hyperparathyroidism. So all these factors should be put in mind. And here, this is a normal gland. If we have perceiving factors like hypocalcemia, hyperphosphatemia, hypovitaminous D, there will be hyperplasia, early nodularity, and then vitamin D receptors and the calcium sensing receptors is reduced again and again, increasing towards nodular hyperplasia, and then we may find even single nodular gland. So we should think of this issue of the risk factors and how to interfere with them in early manner to avoid their culmination. This is one of the studies showing that high-dose cholecalciferol, which is vitamin D3, alleviate the progression of hyperparathyroidism in patients with CKD stage 3 and 4, according to this double-blind randomized control trial after 12 weeks. So we should think of vitamin D deficiency, and because vitamin D has many pleiotropic effects. Cholecalciferol was given in a dose of 8,000 units per day, and the study compared it to placebo for 12 weeks. And here you can fix this table to look at the difference between cholecalciferol and placebo and the change. For example, here in the BTH is stable, but here in the placebo BTH increased, and this reached statistical significance. You can see the difference in all these variables between cholecalciferol and the placebo in these patients. Another interesting point, if we use calcium mimetics like Cinacalcet, we should think of hypocalcemia. because as you see here, there is increasing the risk of hypocalcemia or severe hypocalcemia. Severe hypocalcemia here, this is a severe hypocalcemia, and this is any hypocalcemia less than 8.4, but severe hypocalcemia means less than 7.5. So the black one referred to severe form, and severe hypocalcemia was significantly higher, and hypocalcemia is significantly higher in Cinacalcet use in comparison to placebo. So whenever we use Cinacalcet, we should look at serum calcium. Regarding phosphorus, it's very nice to address the food by omitting food additives, because food additives include an organic phosphate with 100% bioavailability without any nutrient effects, and so we don't need them. So it's better to avoid all food additives in dialysis patients to avoid culmination of hyperphosphatemia. We have a very interesting video tape in Arabic for patients in Arab world about the phosphorus and diet, and we have our own foods in this Egyptian phosphorus map, so for the patients to know which food including the lower amount of phosphorus and is allowed is very interesting. And one of the important messages is to learn how to boil the meat and to get rid of soup. The effect of niacin, this is a study addressing the value of niacin, and after the use of niacin for 3 years, yes, serum phosphorus is lowered by use of niacin, but didn't affect other markers of mineral metabolism in patients with CKD. So it seems not enough. Niacin works here in sodium phosphate transporters, so it blocks this transporter, so it reduces the absorption of phosphorus, and here the phosphate binder work here on the gut lumen, in the phosphate within the gut lumen, to reduce the passive reabsorption of phosphate. So it seems that combining niacin with phosphate binder may help in this domain. Regarding parathyroidectomy, this is a very interesting editorial comments about the parathyroidectomy. Yes, I believe in the statement. It should be the last resort for hyperparathyroidism in dialysis patients. So we should exhaust our resources in medical treatment starting early and concentrating in serial parameters of calcium, serum calcium, phosphorus, and BTH, starting early, look at serial values, and improving the healthcare system. This make a very great job. So the benefits of parathyroidectomy: yes, it cures hyperparathyroidism, definitive treatment, less expensive than the use of other expensive drugs, avoid long-term medication side effects, improve turnover bone disease, considered minimally invasive, but it is risky surgery, induces hypoparathyroidism, irreversible, loss of vital glands, necessitate long treatment of calcium and vitamin D, development of low bone turnover disease, and increased short-term mortality and morbidity. So we should think of all these points. This is the meta-analysis which is assuring, including 15 cohort studies, 24,000 participants, and the results here showed that parathyroidectomy is associated with better survival. So again, especially for patients with very high level of BTH. Again, if we have severe hyperparathyroidism, we should start medical treatment. If medical treatment fails, I think this is a good choice for parathyroidectomy. And this is a very interesting review about parathyroidectomy. And here, he went to consider parathyroidectomy in dialysis patients persistent for more than 6 months, elevated BTH despite maximal, so we should put here 100 line, maximal management with vitamin D analogs and the calcium mimetics. And a patient is a surgical candidate, because sometimes the patient is not a surgical candidate. And refractory hypercalcemia or hyperphosphatemia in the presence of high risk of calciphylaxis or anemia, hyperresponsive to erythropoietin. So all these environments help us to decide for parathyroidectomy. So for surgical referral, parathyroid ultrasound and or technetium system maybe or intraoperative blood beta H sampling. And some authors, some experts like Professor Halawa is not convinced by the routine localization, but it seems that localization may help to select the tissue to be left to the patient. If we find less active tissue, we can leave it to the patient to avoid recurrence of hyperparathyroidism again. So here, after parathyroidectomy, we should monitor for hungry bone syndrome that may occur in 20% of patients. Serum calcium nadir 1-3 weeks post-operative. The high-risk patients, in the young patients less than 45, so should take care of young patients. Post-operative calcium 8.4, high alkaline phosphatase above 120. Pre-operative beta H levels is not predictive of the development of hungry bone syndrome after the parathyroidectomy. Treatment of hungry bone syndrome include high doses of oral and IV calcium and vitamin D. Calcitriol is preferred, and high calcium dialysate 3 millimole per liter. So this is regarding parathyroidectomy. The last corner is transplantation. If we have transplant candidate, the low level of testosterone is associated with low bone mineral density, and the high level of testosterone or normal testosterone is associated with preservation of bone mineral density. High endogenous level of sex hormones were associated with greater bone density in male kidney transplant candidates. Disturbances in gonadal axis may contribute to skeletal fragility in men with late stage chronic kidney disease. Again and again, hyperparathyroidism is bad, especially if it's persistent and severe. And here in this study is considered a real risk factor for long-term graft failure. So we need to detect them early and to look at them pre-transplant and after transplantation. This is the study showing the change in bone mineral density after kidney transplantation, 2-year assessment of a French cohort. And the recent changes, you can look here. This is some refinement in the recent years. But the most important point is bone mineral density is not enough to tell about the bone quality. So bone density, microarchitecture, and the tissue quality is important to be addressed to evaluate the bone in transplant patient, because we may find reduction in bone mineral density but improvement in microarchitectures and tissue quality. So we need bone mineral density. We may look at trabecular bone score index and microindentation by the osteoprobe, as you see in this slide. Regarding the phosphorus, here we considered post-transplant hypophosphatemia is bad for a long period of time, and a lot of factors culminate to cause post-transplant hypophosphatemia, either polyuria, persistent hyperparathyroidism, using phosphate-free diet, phosphate binders, bone hungry syndrome. All these can lead to hypophosphatemia after transplantation. But this study is very nice because it shows that post-transplant hypophosphatemia reduces the risk of graft failure. Why? Because in this study they found that hypophosphatemia is a reflection of good function graft. So this is the other paradigm of hypophosphatemia, and as you see in hypophosphatemia, the hazards for even cardiovascular mortality is reduced. Preemptive transplantation is important because if we transplant the patients preemptively without dialysis, FGF23 is not highly elevated in this scenario. This means that we predict less changes in phosphorus after transplantation. In this study, serum phosphorus, high serum phosphorus, here this is a quartile of phosphorus, quartile 1 up to quartile here, 10 above 4. Here in these patients, the higher the serum phosphorus, the higher the risk of cardiovascular disease, the higher the risk for transplant failure, and all-cause mortality and cardiovascular mortality. So again, and here the transplant and the composite endpoints. So very high level of serum phosphorus is bad after transplantation. And this is the KDIGO 2017 guidelines for evaluation and treatment of kidney transplant bone disease. In patients with immediate post-kidney transplant period, the guidelines recommended measuring serum calcium, phosphorus at least weekly until the patient is stable. If the patient after the immediate post-kidney transplant period, it's reasonable to base the frequency monitoring on the abnormalities and magnitude of abnormalities and rate of progression of kidney function after transplantation. Reasonable monitoring interval, if we are dealing here from stage 1 to stage 3B after CKD transplant, for serum calcium and phosphate every 6 to 12 months, and for BTH once with subsequent interval depending on baseline levels and CKD progression. In CKD stage 4, for serum calcium and phosphorus every 3 to 6 months, for BTH every 6 to 12 months. For stage 5, after kidney transplantation, for serum calcium and phosphate every 1 to 3 months, and BTH every 3 to 6 months. Regarding osteoporosis, osteoporosis is a real important issue in bone disease, in chronic kidney disease, and after kidney transplantation. And if you look in this comparison, after a year of transplantation, as you see, osteoporosis is increasing. Osteopenia, and the normal bone is reduced after transplantation. This is why we should monitor for these points. And this study showed the prevalence and risk of factors for non-vertebral fractures in kidney transplant recipients. As you see here, the bone mineral density predicted fractures. Here, if it's normal, fracture is less. If it is depressed, there is osteoporosis, fracture is increased. So what are the risk factors for fractures? We have pre-transplant risk factors and post-transplant risk factors. Post-transplant risk factors include steroids, persistent hyperparathyroidism, and if there is diabetes, and in vitamin D deficiency. So this is why we should think of all these paradigms as shown in these figures. In patients with CKD after transplantation with risk factors for osteoporosis, the guideline suggested that testing be used to assess fracture risk if results will alter therapy. In patients in the first 12 months after transplantation with an estimated GFR greater than 30 and low bone mineral density, the guidelines suggest treatment with vitamin D, calcitriol alpha calcidol, and or antisorptive agents to be considered. This suggestion based on weak evidence. We suggest that treatment choices be influenced by the presence of CKD-MBD as indicated by abnormal level of calcium, phosphate, BTH, alkaline phosphatase, and vitamin D level. It's reasonable to consider a bone biopsy to guide treatment. There are insufficient data to guide treatment after the first year of transplantation. Regarding vitamin D after transplantation, all these factors are associated with problems in vitamin D. So reduced sun exposure, reduced skin census, use of sun protecting cosmetic, reduced skin census, proteinuria, increases urine loss, development of diabetes after transplantation, decreased intestinal absorption, higher prevalence of obesity, reduced bioavailability, steroids is associated with increased catabolism, and the calcium inhibitors suppressed liver synthesis of vitamin D. This is why we should think of the hypophosphatemia D before and after transplantation. And there are many reports in transplantation that vitamin D deficiency is associated with problems of infections, rejection, etc. Cardiovascular problem, hypertension, because of the pleiotropic effects of vitamin D. So we should think of vitamin D and vitamin D supplementation. This is a study comparing the performance of calcitol versus calcifediol for treating hyperparathyroidism in kidney transplant recipients, and these are the level of intact BTH at different time interval, and the baseline after 1 month, 3 months, and 6 months, and this is the effects of the drugs. Here the blue color referring to calcitol, and the red one calcifediol. And this is regarding vitamin D. Here, as you see, sorry, this is the BTH after 6 months. Regarding estimated GFR, this is the difference between pericalcitol and calcidiol. Here you can find lower kidney function with pericalcitol. The most important point is there is a difference in tissues. Borderline changes is more common with pericalcitol. EFTA is more common, although it's not significant in pericalcitol in comparison to calcifidiol. Whenever we use denosumab, which is Renal inhibitors, we should monitor serum calcium. Bone pain after kidney transplantation is important and may be related to the use of calcium inhibitors. In this case, 9 years of persistent disabling foot pain in a kidney transplant recipient. The recipient was maintained on cyclosporin with reasonable trough level, everolimus, and steroid, with bone marrow edema here in the MRI. So the diagnosis was, after excluding all causes, this was calcium inhibitors, bone pain disease, and the treatment according to the guidelines to reduce the dose or to shift from calcium inhibitors or the use of dihydropyridine calcium antagonist, because there is assumption that calcium inhibitors lead to a vasoconstriction of the vessels of the bone. So if we use dihydropyridine calcium antagonist, this may ameliorate bone pain. In our case here, the response was evident after stopping cyclosporin and replaced by mycophenolate mofetil. So in this presentation, I'll start with introduction, then laboratory coronary stress on FGF23, and the most important from the laboratory parameter is we should look at the serial level, not one point of time, serial level of the CKD-MBD profile and the full profile. And I addressed the uncertainty of the KDIGO, current KDIGO guidelines. One of the important points is to address the risk for fracture, which is osteoporosis. And unfortunately, we don't have well-done studies in CKD-MBD, and we extrapolate the recommendation from the normal non-CKD patients. We need further evaluations. Vascular calcification is bad, and we should think of magnesium. Vitamin D, hypovitaminasis is bad, and we should think of it. Hyperparathyroidism, it's better to start early by looking at serial change of parathormone and to consider parathyroidectomy as the last resort, as I mentioned within the presentation. CKD-MBD is the transplantation is not the magic solution, and after transplantation we may find many problems related to bone, and I mentioned some of them, and I didn't mention the vascular bone necrosis. A lot of the problems are there, and we need further studies addressing CKD-MBD after kidney transplantation. I should stop here by this quotation. All these are knowledges. So knowledge is of no value unless you put it into practice. And the great aim of education is not knowledge but action. This is why I'm dreaming to improve the healthcare system by applying the most trusted algorithms, and I think starting earlier, looking at serial changes, using drugs in a smart way will make a great difference until we have a good research. Thank you very much for your attention, and I'll be happy if you have any question.